I'm Dr. Madeleine Attridge. I'm a GP partner in Barry and also have done some out of hours work in the past, and today I'll be talking to you about the more extreme remote consultations that we've been having to do, such as in COVID-19. So in the COVID-19 pandemic, we are being asked to consult by video or phone in situations where we would normally be expected to bring the patient in. We are going to talk about the situations where it would be normally considered bad practice not to actually physically see the patient, unless of course you're consulting in the Australian outback, where they've been doing this for a while. In COVID-19, actually seeing the patient might not be the best option for the patient, yourself or your colleagues. Again, remember the key points of any video consultation, as I've discussed in some previous tutorials, which you're welcome to view. Always document if you can't get hold of the patient and what time you try to make contact. I often document 2 attempted contacts, at least sort of 20 minutes apart. Ask to speak to the patient first and then introduce yourself. This is an important confidentiality point because a relative might not realise that they've called the doctor even. If you're not speaking with the patient for the consultation, you're speaking to a relative or carer, then try and speak to the patient at some point, even if it's a child, just to sort of get an idea of how breathless or how unwell they sound on the phone. Make a point of documenting more than you would normally do for a face-to-face consultation, as you actually need to get more of a picture of the patient, of how unwell they are, rather than just relying on observations such as blood pressure and pulse and things. And it's important at the end of the consultation to check that the patient is happy with the outcome that they've had via sort of telephone or video consultation, and safety net more than you would normally do. So you might be worrying about all the ethics of managing patients remotely most of the time. However, you'll find that medical ethics can be used to support your decision making. So let's take the example of a 30-year-old lady with simple low back pain for 2 days requesting to be seen. So looking at beneficence and non-maleficence, weigh up what additional benefit will this exam bring? What is the harm in face-to-face contact for the patient and those who they live with? If they got COVID, how serious would it be for them, and what are the risks of not being seen face-to-face? In a lot of cases, a face-to-face exam will bring little change to management but increase the risk of COVID-19. The patient may feel a back exam and an x-ray is in their best interests, but after some explanation you can discuss how, with no red flag features, her coming to the surgery will not bring any additional benefit. And given the increased risk of COVID to her actually coming into the surgery, the most beneficial option is actually just to manage and support remotely. You can give sort of links to back pain exercises and just general advice. Looking at non-maleficence. Let's say this lady isn't worried about her risk and therefore adds a bit more pressure on you into coming in. You see her, and unknowingly you transmit COVID-19 to her family, which includes her husband, who was in ITU last year with asthma. Here, although seeing her may not cause direct harm, she may receive indirect harm that she hadn't even considered herself. And then justice. It's always important to look at this as well. In the reverse, she unknowingly has transmitted COVID-19 to you. This required you and your partner, who's also medical, to have 7 to 14 days off work. So in effect, up to 4 weeks of clinical care has been lost. Is this fair to other patients that their quiet care is being compromised when it wasn't necessary to bring her in? You need to view yourself as a valuable resource which needs to be managed carefully. Expose yourself only when deemed necessary. So now I'm going to run through the clinical conditions which I've previously discussed in other tutorials, and which you're welcome to have a look at before seeing this one as well. But this time I'm adding more of a slant on the more extreme management required during COVID-19. So firstly, sore throat. We talked about how we can encourage the patient to examine themselves to tell you if there's tonsillar enlargement or swelling. In those cases where they can't see the tonsils, whether were unwell or had a high fever pain score, you might previously have been encouraged to bring them in. However, now bringing them into the surgery is actually your last resort. You're going to explain to the patient that tonsil exam is not recommended in COVID-19, and that actually even if they came in, you're not going to examine them anyway. If they can't tell you what they find on examining themselves, then you're just going to automatically give them a fever pain score, starting score of 2, and then add extra bits on depending on their history. You can then use this to discuss how likely antibiotics will work, as we've mentioned in the past. For example, fever pain score of 3, there's a 50 to 60% chance antibiotics won't work. And remember to use all that counselling about how, they're going to get better after 1 week regardless. Obviously, you need to use antibiotics when the patient is very unwell or you're concerned. Remember, the fever pain score is not validated under 3 years, but the Royal College of Paediatric Guidelines has said antibiotics should only be used for this in this group for scarlet fever or exceptional circumstances. So you can discuss that with the parent on the phone. If they've got a 2-year-old who they think has tonsillitis, you're going to talk about how, if they're okay with it, they really aren't going to get antibiotics because it's not going to bring much benefit. I'm going to talk her through a case example now of somebody with a sore throat who was brought down to my hot hub when I was working. It was a man who was on methotrexate and an anti-TNF injectable and had a sore throat for 9 days, but a little bit worse recently, but was still systemically well. Actually bringing this patient down, I'm not going to be able to examine his throat, so there's not really any benefit to him. His obs are going to be normal because he's systemically well. And yet for him, there's a significant risk of COVID. If he gets COVID from coming down to our hot hub centre, he's going to be extremely unwell with it. He's almost on the borderline of being in the shielding group. For him, it would be actually in his best interest to prescribe him antibiotics and safety net about blood tests and whether they're actually needed, given that he's on methotrexate with a sore throat. So for the next example, we're talking about earache. I've talked previously about checking for red flags and the signs of mastoiditis by getting the patient to examine that part of their ear. So then you need to ask yourself, can you reasonably treat for the most likely diagnoses and safety net for the serious differential you may have missed? For example, the middle-aged patient with a painful ear for 3 days with discharge and no other red flags. Yes, an exam might help you decide between otitis externa and media, but if you just treated and covered both, or if versus seeing the patient and exposing them and you to COVID, which would be better? Yes, you might be prescribing antibiotics unnecessarily, and I'd also suggest the non-ototoxic topical antibiotic like ciprofloxacin, but the short-term harm of prescribing the antibiotics is less likely to be harmful than the harm of actually risking the patient to getting COVID-19 through a close exam, and yourself and your colleagues also. Headaches, a fairly simple one. Can they do their own blood pressure? Can you make a diagnosis with a thorough history and examination by video if needed? And what are the serious pathologies that you're potentially missing out? Can you exclude those just on the phone video, or safety net for them enough that you can just continue it? Okay. Next, we've discussed back pain in a previous tutorial in more depth, but we're just going to go over the more extreme version. Most simple low back pain, it does not need examination unless there's red flags. If you do need to do an examination, you can do this by video. Just check their sensation. They can do a straight leg raise test. The only thing you're missing is reflexes. If they have symptoms of cauda equina, you could admit them directly. You don't need to see them at this time. If they have weakness suggesting a disc prolapse, can you just discuss this with the orthopaedic surgeons or refer them to the orthopaedic surgeons? Do you actually need to see them? Is doing their reflexes going to change whether you refer them for an MRI or discuss them with trauma and orthopedics? It's probably not. If they've got persistent weakness, you're probably going to want to discuss regardless. Okay. The next is pyelonephritis. So, it's quite clear that UTIs can be managed over the phone easily, but in COVID-19, I'd suggest managing pyelonephritis remotely as well. If they've got classic loin pain, tenderness, and urinary symptoms, and you can be reasonably confident this is what they've got. if they're unwell with pyelonephritis, you're going to need to make a decision whether to admit them from home or treat them with antibiotics and antiemetics. So you're going to need to take a detailed history, getting a rough idea of how unwell they are. So how is their fluid balance? Are they able to drink fluids to a level to counteract any vomiting? Are they passing urine well? Can they check their own pulse and explain how to do that? Are they able to stand and for how long? Because that sort of gives you an idea of how their blood pressure is. If they're really not able to stand, then they've got probably got quite a low blood pressure and are probably quite unwell. And with pyelonephritis, you need to check for any conditions, meaning they're, at high risk from deterioration complications. So if they're unwell with pyelonephritis and they're pregnant or they're very elderly or a lot of kidney history, then you're going to be erring on the side of just admitting directly. So you need to counsel the patient that this would normally be managed face-to-face, but you're trying to manage by phone due to the risk of COVID-19. So they understand why you're not actually examining them and things. You need to counsel the risk of, you're going to try and treat at home because it would be actually quite dangerous to have COVID-19 and pyelonephritis. But if you feel it's necessary, you are going to admit, okay? You're going to safety net and make sure that they send a urine sample for testing as well. I'm just going to discuss now the case I saw recently. So I had an 18-year-old who had loin pain, and she had a history of recurrent pyelonephritis and UTIs, and she also had a history of a duplex kidney. So she is somebody, who is a bit more risk. She presented unable to keep any fluids down. She was vomiting persistently. She wasn't drinking much. She was dizzy with standing. She wasn't weeing as much as normal. So we started off by just doing an examination. So I got one of the family members to check her pulse and explained how to do this, and they were able to do that perfectly for me. Pulse 82. They were able to check her temperature for me, or just, if they haven't got a thermometer there, you can always get them just to feel the forehead and give a history of a fever. She was able to stand for a couple of minutes for me as well, and actually looking at her other video, seemed to be quite well perfused. We had quite a lengthy discussions because she would be normally one actually that, because she's not tolerating fluids and she can't keep things down. She'd be one that we'd normally admit to hospital. However, she didn't want to go to hospital, and nor did the family wanted to go. So we discussed about, the advantages of hospital and the risks, because there is a risk of her having COVID-19 as well, versus, we could trial antibiotics and an antiemetic. And she decided that she'd rather give it a trial for 8 to 12 hours with antibiotic and antiemetic. And actually, she took those. We gave a follow-up safety call the next day. She was better. She was already improving a little bit, and she's much better 4 days later again. Okay, but it's very important in those sort of borderline cases that there is an element of patient choice, and you've discussed that with them. So next, for dermatology, the sort of resolution of video is not very good, so I generally say this is only for sort of generalized rashes and eczema, where you want to see the distribution of its severity. I asked them to email me a photo for skin lesions, either to a phone in the surgery that we use for that purpose, or an email. And then if I'm still not sure what I think it is, I'll actually then go and email the dermatologist locally. They've already got a teledermatology service, but if yours hasn't, you could just email your local dermatologist and they'd be more than happy to diagnose things just on a photo. I've always just emailed them my smartphone photos rather than the sort of proper camera photos, so there's no difference to the patient just sending a smartphone photo. They've always been happy to use that, given the quality is so good now. Cellulitis, that often occurs in a lot of our housebound patients who often can't use video consulting for various reasons. So in those circumstances, I often treat empirically, and you have to balance the risk that you might be giving antibiotics where they're not needed, and they might just have venous eczema. But this is a very vulnerable group, so actually, you going in and doing a house call is quite high risk, and it's more high risk than them having the antibiotics. Care home consultations. Normally, these are patients we often do visit, but actually, even before COVID-19, some health boards were already trialling video consults for these patients. And they're fairly easy to manage by video consult. I typically ask the carer to allow me to video call them, and then we proceed with it. And I get the carer to do the exam for me. So obviously in nursing homes, they're quite familiar with doing OBS and things, but residential homes, I'll teach them how to do the pulse rate, the rhythm of the pulse, the respiratory rate, and then they can use that for next time we're sort of consulting. We've asked our care homes to get sort of stats and blood pressure monitors as well. But you don't always need those. Like I've described, you can sort of use other measures to sort of get a rough idea of their blood pressure. It is out of the scope of their normal residential home work, but essentially they are their carer, and we're asking them to provide the same level of care that we'd ask a family member to do. So, I don't see any problem with that really. Now, then there's a bit more, there's another sort of difficult part with dealing with care home consultations. You have to think about, can you treat this empirically, such as a chest infection, UTI, constipation, based on the information available? And then think, what additional benefit would an exam bring? What's the risk? Remember here, the risk is even more significant than your frail patient at home, because not only could you bring COVID to that patient, but you could bring it to the whole care home, okay? And they're all very frail typically. So in the very frail patients with COVID, you really need to think, can you reasonably manage this patient and their symptoms without seeing them? It might be in their best interest to actually have a face-to-face assessment. But then you need to think that actually by seeing them, you've then contracted COVID and passed this on to other patients of your practice and staff as well. So what's always in their best interest might not be in, fitting with justice in terms of others. So you sometimes just have to balance what is fair, can you manage this patient well enough over the phone by video consult to give a reasonable standard of care and not put yourself, your other patients at risk. That's particularly when the actual resident's got COVID-19. You really need to think, is it going to change much if I sort of visit them, or is it not going to change the management much? And then I've just increased the risk to my patients and staff. So we could go on to discuss forever about all the individual scenarios, and there's many more sort of that we could think about. But I hope you've seen from these examples how you can weigh up the cases based on the ethical principles of beneficence, non-maleficence and justice, and allow the best treatment for them under the circumstances and protection for everybody. Remember that you need to try and discuss things you're not sure about with colleagues. So you can ask online on forums like Resilient GP and TICA's GP group, or on Facebook, or even set up your own WhatsApp group if you're not on Facebook. You can use these. They're quite useful because if what you're doing is consistent with what others are doing, that supports your actions further. Okay. So that's the end of our tutorial today. Just remembering it's important to do a proper introduction, confirming the patient, do a thorough assessment, taking a full history, and using the ethical principles to work out, is it just that we do a face-to-face consultation here today, or is it in their best interest to manage things over the phone?